Hi, it's me. It's Shirley Gutkowski with a new episode of The Spot for Health, where Sun Prairie goes for health care. And I am going to be talking today in two parts, and we're going to be spending our time looking at a tongue tie. I'm finding that I have a lot of patients whose tongues are tied and no one's ever told them. And this kind of leads into a lot of different problems and conditions that you may never even think are caused by something like a tongue tie. I am the owner of Primal Air, OMT, and breathing retraining, and we just finished our first class on breathing retraining just last week. And it was fantastic. People were very amazed at the reduction in the amount of anxiety that they felt. So that's my little commercial. I don't know if I would even want to call it commercial. So at the beginning of this, I wanted to start with a little bit of a quiz, just so that people can kind of know what I'm talking about. My practice manager, Philip Gutkowski, is always like, "Mom, you have to use better language. Stop talking like a dictionary." So I thought we would start with a couple of keywords here so that we're all kind of on the same page. And first of all, I wanted to take a look at the tongue and ask a true or false question. The tongue is only for talking or tasting. True or false? It's false. Now we'll go into why that's false as we make our way through this first half of this tongue-tied episode, this two-part tongue-tied episode. So this is the next question. Which of these two rotating heads here is a maxilla? Is it A or is it B? A is the maxilla. B is the mandible. So when you're talking about the face and the bones of the face, the two most prominent bones are the maxilla up here and the mandible down here. Maxilla, mandible. And then the next quiz question is, where are the tonsils on this picture? Is it A or B? The tonsils are A, and they're located behind the tongue, and there's two kind of clumps of the tonsils on the right and the left side. And lately I've been seeing a lot of really gigantic tonsils, and they can impede the airway as well. The other piece, the next question here is, which is the tongue, A or B? In this picture, obviously it's B, and I'd like to point out where the tongue is reaching up towards. That's going to be our next little quiz question here. The next quiz question is, which is the sinus, A or B? This is a cross section, right, of your head where the whole right side of the head has been removed and you're looking at the left side. And you can tell by this picture that A is the sinus. And I'd also like to point out that B was the adenoids, which you cannot see unless you're using a scope, but they also contribute to impeding an airway. And then there's the maxilla again. On this picture, you'll see that it is also called the hard palate. So the maxilla is called the hard palate, it is called the roof of the mouth, it's called the maxilla, and it is also called the floor of the sinus. So that particular bone has a lot of jobs, a real lot of jobs. So it's very exciting to be talking about that. The maxilla also comes in three parts: the right part, the left part, and then a little tiny part that holds these first front teeth in place. That maxilla is supposed to fuse by the time you're in your 20s, and we're finding now in dentistry that maybe we can even stretch that maxilla if you're an adult. So what is a tongue tie and why should we care? In dentistry, we kind of look at the tongue pretty like, oh, it's a pain. Can you talk? Can you eat? Can you move it to the right? Stop fighting me with your tongue. Let me hold your tongue with the mirror. So we have all this weirdo relationships with the tongue. We just really want to know, can you talk and can you eat, and then call it good enough. And for some reason, we've kind of left this left this idea that the tongue has more jobs than just talking and eating. We've kind of been focusing on fixing teeth, and we learned a lot about the tongue. We know that the tongue has different areas of taste and different ways to move the food around when you're eating. What we've forgotten in our normal daily routine is how important the tongue is for sensory and motor information. You can see by this diagram here that when we look at the face and from the eyes on down, we have a pretty big percent of sensory and motor activity coming from that part. That is 33%, almost a third. It's about 33%, let's say it that way, of all your motor and sensory information is coming from that part of the face, from the eyes down and back. So we're sitting here now in dentistry scratching our head because we've kind of focused on just making sure patients have really good teeth and that the teeth are sound and that you have enough teeth, and we've really lost, this is kind of a broad brush, but just generally speaking, the focus on some of the other things has been put to the side a little bit, and we're going to be moving that forward today with today's discussion because we're realizing that the tongue also affects the airway. The airway is the most important part of this whole equation. Here's a study here that you can't read, and even if you had a close-up, you probably couldn't read it, but this is looking at childhood obstructive sleep apnea, and they're finding that obstructive sleep apnea is a problem of facial growth, and that's where the tongue tie comes in. The tongue is what grows the maxilla by pressing up against it, and it adds pressure so that the maxilla will expand and move forward. And if it's tied down to the floor of your mouth, you're not getting the true benefit of the whole maxilla and increasing the size of the maxilla to what they're calling, the great and powerful they, are calling the genetic potential of the maxilla. These are examples of tongue tie right here. You can see where children and adults alike are suffering or having this tongue tie condition. And even children that are sucking their thumb often are doing so because their tongue is tied and because they're missing out on getting some of the airway, some of the benefits of the airway. Here's a short list of some of the symptoms in mother-infant pairs when the infant has a tied tongue. You can see things like difficulty in nursing. You can see that the breast may have mastitis, or there may be thrush involved, which is a yeast infection, a compromised milk supply. The baby may be having reflux or colic. They may be gassy, not a good weight gain. Choking often on the milk is another cardinal symptom. So these are symptoms that you would see in an infant that has a tongue tie. I've been talking to a lot of lactation consultants and lactation specialists, and they're getting to be pretty much in tune with what needs to happen for, or not what needs to happen, but identifying these tongue ties in infants. And doulas are also being alerted to this tongue tie problem. It's bigger than we thought. I'm surprised at how many adults have tongue tie, and that has never been addressed. So this is something that is causing a lot of problems in the world. These are some examples of tongue ties, and we have them kind of categorized. So a normal tongue would allow the tongue to move up and down, left and right, forward and back in all these dimensions and have a strength. If it's tied, what we call anterior, that means that this little tissue that you can see in this picture here, this little tissue is attached too far to the point of the tongue, too far forward. And if it's short, then it doesn't allow the tongue to move up and down. So it can be anterior, so that means that it's attached too far forward, or it's short, and that means that it's not long enough to allow the tongue to get fully up into the palate. And then we have the anterior and short. So it could be that they're both showing up, or it could be a situation that we call in our textbooks ankyloglossia, which is where the tongue is completely immobilized. This is usually where dentists and oral surgeons and others become involved. So this is too long, right? So we want to be able to address these issues a lot earlier. If you're home right now and if you have a mirror handy, you can check to see what level of tongue tie you have yourself by opening your mouth as wide as you can without causing pain to your jaw joint. Okay, so this is just one of a little array of tests. So open as widely as you can, and then put your tongue to the roof of your mouth right behind your upper front teeth. If your mouth closes over 50% in order for you to achieve that touch, that is a sign that you have a tongue tie. So that's something that you can bring to your dentist or bring to your dental hygienist's attention and say, you know, this looks like I have a tongue tie. What's that about? So that is one of the functional tests that we do. You can also put your tongue into your into your cheek and see how far you can get it to push out. So that's another functional test that we do. If you can't reach and push your tongue into your cheek, that's a problem. So where did we get all this from? How did this happen? Why did it happen? And we've got a new way of looking at dentistry called Darwinian dentistry or ancestral dentistry. There's a couple of little terms like that that we're using to describe going way far back to see what normal used to be and see what normal is today. And this is a slide that I got from Dr. Kevin Boyd. You can see his name there in the bottom right-hand corner of this slide. And what he is doing is really wondering aloud and pointing out some problems with what we're calling normal today. And what he's saying is that in these lactation textbooks and in dental textbooks and in all kinds of textbooks that look at the mouth, suddenly we are saying that the mandible, right, the lower jaw, is too far back, and that is normal. They're saying in the textbooks that that's a feature that allows the fetus to be expelled during birth. And what he's finding by his studies with skulls and going down into the basements of these, these museums where they have skulls from hundreds of millions of years ago or for however long, and finding that that's not true at all, that the jaw has never been back as far as it started to be about 150 years ago when we started to really ramp up in our industrialization. So we have what we're calling a new normal that doesn't fit with what we know ancestrally. And actually he goes to call it horse apples, but I switched it to say horse apples. That's not true. He used stronger language. And what he's building on is this idea of epigenetics. Epigenetics is a way that ancestrally we activate or deactivate DNA sequences to appear. In the olden days, before bottles, if a baby was tongue-tied, that baby couldn't nurse because it was too painful for the mother, and often that infant was abandoned. And so what happens with an abandoned infant? No, mostly they don't go to the wolves and turn into Tarzan. That's not how it works. Usually those babies perished. So it's real important that we put this in context. So in the 1800s sometimes we invented bottles, and then those infants were rescued from that kind of a situation, and they were at least nourished. But what we didn't do was take care of that tongue tie, and that's a problem. We have a lot of DNA. We know what DNA does. It expresses different things like eye color, whether or not you have to color your hair, whether your skin is this color or that color, big feet, little feet. But what we didn't understand until about 2007, when we started to really ramp up on this, is this idea that we have histones that are attached onto the DNA. And the histones are these little purple balls that are on this photograph here. And those things are very affected by the environment of the person hosting that strand of DNA. So whether you're stressed, whether you eat too much or too little, whether or not you're chewing, that's all getting translated onto those histones, and then those histones are turning into a completely other way of activating that DNA sequence. So you may or you may not even have that available. So for tongue tie, for instance, now that we are so industrialized and our food is so, I don't know, minor, that we don't have to chew, that it's easy to get, you don't have to fight for it, you can have a variety, and you can eat a mono diet. All these things are translating into that histone, and there's something called methylation. And this methylation is not something that I understand really well yet, but it's for the tongue tie especially, it's this difference between folate and folic acid, where folate is in food and folic acid is what's usually given to new or wanting to be mothers. Okay, so young women who are looking to be mothers, they're taking folic acid when maybe they should be taking folate, and they're wondering if that little thing, that little difference there, is causing more and more of these tongue ties. Plus this idea of not chewing. This is the perfect picture of not chewing. Bread used to have crust, and you used to have to chew the crust. This is one of these little red flags, too, with our children. If they can't eat hard or crunchy foods, that is also a symptom of a tongue tie. So if they're real fussy eaters and they won't eat crunchy foods, then we have to look further and say to ourselves, what's happening to this kid? I know this sounds like a lot of blah, 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 but we're getting on to the point. It's not that far-fetched. This epigenetic piece is really important in a lot of different medical conditions, and this is just one of them. And this may be the first time you've even learned about it. So this is what a tongue tie could look like. This would be a true ankylosing situation. I'd like to point out that not only does this person have this tongue tie, this person has seen a dentist. You can see that this person has a stainless steel crown. It looks like they may be about 8 years old or 9. You can see, if you're real close to your television, that there's decay in a tooth there on the right, and there's a filling in that tooth, but no one's ever addressed that tongue tie. We have a very high tolerance for tongue tie in dentistry, and it's really kind of uncomfortable. How to know if your kid, your baby, your child is getting a good dental exam is to make sure that the dentist is looking like this. So the mother and the dentist are looking at each other. They have their knees together. The baby is on the mother's lap, facing the mother. And then the mother uses her elbows to hold, this picture doesn't show her using her elbows to hold the kid's feet down. And then the baby lays back into the dentist's lap. And then the mother holds the baby's hands so that the baby is kind of pinned, but the mother's pretty much in total control. This allows the dentist to get a really good look at what's going on in that baby's mouth. And that's really the best way for that dentist to see these ties. And that's the critical piece. It has to be identified before it can be adjusted or released. So that was Dr. Larry Kotlow's picture. He is a famous tongue tie dentist tongue tie release dentist in I believe, New Jersey. He has clients flying in from all over the globe to have him release the tongue tie on their children. The other thing that he's looking for, and most pediatric dentists are looking for, is this condition right here where the lip is tied. We're starting to identify this tied lip in children as being a component of early childhood caries. You can see in the right-hand picture there, that little spot on the tooth, that's a cavity. That's an early cavity. And the white areas around the gum line of those front teeth is enamel breakdown just before it becomes a cavity. And on the left-hand picture, you can see how milk could pool up there and how difficult it would be to get the milk out of there. So breast milk and regular milk are not causing the cavities, it's the pooling, it's the structural element there that's allowing the milk to be problematic. And that's really important to understand, that we are looking at all of these things. So this is Dr. Mew, Dr. Michael Mew. He is the third in three generations of orthodontists in the UK. And he has a number of videos on YouTube, and I would encourage you, if this is something of interest to you, to go and look at some of his videos on YouTube. And what this video here is about is how the tongue is supposed to act against the maxilla. The tongue should reach up completely onto the maxilla so that you have a pressure point, so that the tongue can apply the pressure it needs to grow that maxilla to its genetic potential. That's incredibly important. And when the tongue is tied, it's not doing that. And so why do we care? Who cares if the tongue is up there or not? Who cares if the maxilla has attained its genetic potential? We all do, because remember that the maxilla is also the floor of the sinus. And if the tongue isn't up there expanding that maxilla, the sinuses aren't growing either, and then your airway is completely compromised. And you develop a facial kind of a outline like one of these pictures. So A is normal, where the mandible is at a small degree of an angle to parallel to the floor. And you can see how gigantic those sinuses are in picture A. In picture B is when the tongue is tied and doesn't reach up there into the maxilla, and it's pinned to the floor of the mouth. And then you get this other kind of a development in the face. And then C shows what happens if the maxilla is not expanded and the person is struggling to get air. So everything is kind of crunched up in the back where the airway is, where the tonsils are, and the adenoids. And so the person, you can see their head is kind of stretched forward like this, and they're looking for air. This is problematic for balance, especially as we get older. We can't have our head hanging way over like this. It's causing a bunch of problems down here in the neck and shoulders. So that's another way that this tongue tie is affecting your entire body. It's crazy. So if your sinuses are too small and your tongue is pinned to the roof of, or to the floor of your mouth, you risk having this long face kind of a syndrome. I had a patient a couple of weeks ago that looked just like the Your Child picture there. He had a very long face. He had $10,000 worth of dental work that needed doing. He had already, at 15 years old, he'd already had a root canal. He needed at least one more and a completion of the root canal. His lips were open, just like this picture, just like Napoleon Dynamite, and the actor who played Napoleon Dynamite is in that third picture there. And his lips were very, very dry, and they had like little blood spots on them from where the lips had cracked. Because when you breathe through your nose, you moisturize the air, and when you breathe through your mouth, you just have this cool, dry air streaming past your lips all day, every day. You can see on those pictures too that there's a certain demarcation that we see as dental professionals on the tooth itself, underneath the lip, that's different from the part that's exposed to the air constantly. So this is problematic. Mouth breathing is not something that we want our patients to do or to have. You can tell yourself if you're mouth breathing, particularly at night, if your tongue is dry in the night, if you have to wake up and drink something because your tongue is kind of stuck to the roof of your mouth. The tongue belongs on the roof of the mouth. If you can't reach it to the roof of your mouth, then you need to seek professional attention. So these are all important features in why this tongue tie is so important and how it affects the airway. So let's take another little look at the next thing that happens with a tongue tie, and that would be mouth breathing in the night. Almost a third of children are sleeping with their mouth open. Infants to regular-sized kids, all the way to teenagers, and it eventually ends up being in adults. And that is problematic. When you're not breathing through your nose, not only do you get those structural problems that we just talked about, you also don't get the chemistry that happens up in the sinuses, and you lose out on a lot of growing and a lot of the growth hormones that are released during the REM sleep. This is a study here that shows the symptoms of sleep-disordered breathing in 5-year-old children and how that's associated with sleepiness and behavior problems. We know, it's not that we now know, we always knew that tired children were crabby and cranky, but what we didn't really realize until recently is how this has translated into a completely different area, that these children are now being identified as ADHD or ADD, or what is the one that starts with an O? I can't think of it right now. It'll come to me in a second. Obstinate behavior. Oh my gosh, it's totally out of my head. In any event, these children are being labeled as having behavioral problems when really it's a sleep problem. And this could be solved earlier if in dentistry that we were more aware, and that's happening, and in teachers when the teachers are more aware, and the student school nurses can be more aware of looking for sleep disordered problems in these children. So that's our time for today. Thank you so much for joining us today on The Spot for Health. My name, as I said, is Shirley Gutkowski. If you'd like to learn more, you can visit our website at primalair.com, or you can call the office and talk to me or talk to Philip. He knows a lot about it also. And I'm so excited that we're able to bring you these kinds of things in A Spot for Health here in Sun Prairie. So now that you know where to go, keep going, and we'll see you in a couple of weeks with part 2.